Hello everybody, I'm Jordi Anton, Head of Pediatric Rheumatology Department at Sant Joan de Déu Hospital and Professor of the University of Barcelona, Spain. For those connecting live today, welcome to today, Tuesday, Lunch with Rita webinar, the last one before the summer week. For those in the future watching this recorded video in the ERN-RITA website, welcome, and don't miss other useful educational resources from our ERN. Today we will talk about uveitis, how to diagnose it, how to treat it, and what are the last updates from trials. For that, we have two great speakers, Professor Gabriele Simonini, Chief of the Pediatric Rheumatology Unit at Anna Meyer Children's Hospital in Florence, and Associate Professor in Pediatrics at the Pediatric Rheumatology Unit. He's also Senior Honorary Clinical Research Fellow at the Clinical Epidemiology Unit, Division of Applied Health Science in the University of Aberdeen, King's College, Scotland, UK, and researcher at the Neuropharma Department, University of Florence. Professor Simonini major research interests include uveitis in children with JII, between other rheumatic diseases in childhood, and he hosted a few months ago the successful first uveitis press course in Florence. Professor Simonini will start talking about treatment, current guidelines, and evidence from current meta-analysis. Gabriele, the floor is yours.
Okay, thank you, Jordi, for this kind presentation. I'm really happy to be here to share with you the current knowledge regarding treatment of uveitis. I'll try to share my screen. Can you see my screen, Jordi? Can you advise me?
We can see it.
Oh, that's perfect. Thank you. So, why we should talk about uveitis? As you may see here, over the past 2 decades, publications on uveitis have undergone significant growth, and these publications overall come from worldwide, and there are several countries that are more representative, but overall, uveitis is a question that regards research. And so as you may see here, the term uveitis is really redundant and recurrent in literature. So we need to know something about uveitis. We need to know how to treat uveitis, because now it is not just a problem regarding the most frequent in childhood chronic uveitis, the JIA associated uveitis, but overall all the related autoimmune uveitis, and of course the non-infection idiopathic childhood chronic uveitis. You may be aware that roughly 6 years ago, according to the overall more global share initiative, a group of experts provided the recommendation for the diagnosis and treatment of uveitis. But more recently, an expert panel of pediatric rheumatologists and together with pediatric ophthalmologists reviewed the previous recommendation and tried to update the 2018 share recommendation. So according a new research literature, and pairing a pediatric rheumatologist with a pediatric ophthalmologist to review all the 37 eligible publications by a classical nominal group technique, this group provided a new and update 14 recommendations regarding the management overall, the management of the childhood chronic non-infection uveitis, including the JIA uveitis. I will try to narrow this presentation to specifically to the treatment and to the recommendation that belong to the treatment. As a matter of fact, now in 2024, we truly understand, we truly persuaded that childhood and overall chronic uveitis are a systemic disease. So they deserve a systemic treatment. And the systemic immunosuppression in active uveitis is recommended from the beginning if there are present from the beginning some prognostic factor regarding the disease activity, such as poor visual acuity, or from the beginning the presence of an important complication that significantly affect the visual acuity. And of course, the other indication to start the systemic treatment is the lack of remission on treatment over the disease course in a time that has not to be more than 3 months. So within 3 months, if there are no complications, if there are no situations that affect the visual acuity, nonetheless, the uveitis is controlled by the topical treatment. It is still indicated to start an immunosuppressive treatment. At the moment, methotrexate represents still the first choice treatment as a systemic immunosuppression. But the new recommendation also think that mycophenolate mofetil can be a valuable option for some type of childhood chronic uveitis, and not just GA uveitis, but overall chronic anterior uveitis. Moving from this evidence coming from more than 10 years ago, at the present, something is not going very well regarding the use of methotrexate as first-line treatment, even though the recommendation still say that methotrexate represents the first choice. Since, as you may see from these retrospective studies from an Italian group, it appeared that methotrexate used as monotherapy, although effective into the early stage of the GA uveitis, showed a loss of efficacy over the time. And so not having more the capacity, the ability to keep in remission the disease. But there are conflicting results. More recently, this is a retrospective study from a quite huge cohort coming from a Dutch study led by Joost. You may see here that instead, in this study, methotrexate result is associated with a reduced GA uveitis onset in patients with biological naive GA. So, as a protective role of methotrexate reduces the chance to develop GA uveitis over the course of the GA disease overall. However, as a matter of fact, there are from the beginning some childhood chronic uveitis who have a low chance to get remission on methotrexate and MMF overall, and particularly when the uveitis involvement is a posterior involvement with especially retinal vasculitis. So this is a things to take account, because having this feature, the chronic uveitis probably deserve a more quickly use of the biological treatment. And which biological treatment? Of course, now there is no negotiation. According to these 2 randomized clinical trials that Ram will be explained better than me in detail in the next part, of course, adalimumab is the first choice of anti-TNF-alpha treatment in case of methotrexate inefficacy or intolerance. I think this is most important, or switching to adalimumab. Again, no negotiation that a tablet that it is not at all the right choice for treating JA-related uveitis and overall chronic uveitis. But the body of evidence over time explained us that according to this more recent meta-analysis, adalimumab showed a significant superiority efficacy regarding comparing to infliximab as first anti-TNF-alpha treatment. This has to be taken into account. So comparing head-to-head adalimumab and infliximab as the first anti-TNF-alpha treatment used, adalimumab showed, according this meta-analysis, a superior efficacy in keeping in control the disease. And we believe that adalimumab is really a right choice, at least from the beginning, that in case of lack or loss of efficacy, we have to afford to use as much as possible adalimumab, increasing the dose or switching from every other week up to weekly adalimumab before considering to changing the drug. This gives us the chance to discuss a little bit regarding the clinical impact of antibodies anti-adalimumab, antibodies anti-drug. Well, there is no enough evidence to recommend to test these anti-drug antibodies, even though they are suggested. Since the results coming from literature are really conflicting, it is not really clear among the different cases series reported if the anti-drug are really related to a reduce of activity. There are case series that showed a strong correlation with the disease activity and the detection of these antibodies, and there are cases here that showed exactly the opposite. This is our experience using a specific homemade peptide, using a different assay from ELISA, addressing in this cohort, this small cohort, no more than 50 patients, that the activity of uveitis can be related to the detection of these these antibodies, anti-drugs. But we feel that probably the reply to this question will come from this prospective multi-center trial coming from Philadelphia, addressing the association between uveitis activity, blood level of adalimumab, and drug antibodies, collecting multi-center experience. So moving on, what next? What next once, in any case, over the time, adalimumab does not more make the job, lose efficacy, and even considering that there are few patients that do not respond from the beginning up to anti-TNF-alpha treatment. So the question is if it could be right switching to a different anti-TNF-alpha treatment, as infliximab. You may see here that this is a recent experience coming from RAM, addressing that there is a real efficacy using infliximab after in patients who refractory to a previous adalimumab course. And of course, the other possibility is using, according to this old, let's say, old evidence coming from an Hispanic group, the use of tocilizumab, the anti-interleukin 6 receptor. because providing this evidence, there is a strong relationship between the use of tocilizumab and the immediately resolution of posterior involvement of chronic uveitis of node macular edema. And Ram will explain us better the result of the aptitude trial. And differently from the beginning of the use of tocilizumab, recent data also show that even the subcutaneous treatment is a right option and can do the job as the intravenous treatment according to this experience, this other additional experience, or this other one. So even though coming from small cohort case series, there are a growing evidence that even the subcutaneous treatment by using adalimumab is effective in keeping the uveitis under control. So now the question was, after adalimumab failure, if it is a right choice switching to a different anti-TNF-alpha treatment or changing completely the treatment strategy using a different biological treatment, so swapping. We conducted a recent meta-analysis really addressing this question. So coming from 23 eligible paper, we enrolled 150 children, and we observed that there is no difference at the moment, according to the recent literature, that to switch is superior to swap or vice versa. So changing the anti-TNF-alpha treatment in another anti-TNF-alpha treatment or using another different class of biological treatment are both the good solution with non-different in each other. But going more deeply in analyzing the result, we observed that some drugs do the job better than the other. And these drugs are infliximab with a high chance to achieve the remission and tocilizumab. So we addressed using this meta-analysis that the superiority of tocilizumab and infliximab once adalimumab failed to keep under control the uveitis. And what next? Even though these two additional weapons failed, well, now there is a landscape of possibility, but not really consistent result. There are some evidence coming from the use of rituximab, as well as much more conflicting result regarding the use of abatacept. You see these case series addressing good result using abatacept. Instead, this Deutsche cohort showed us that the results are not so extraordinary using the abatacept. This is the only available randomized clinical trial regarding the use of abatacept. And as you may see here, the results are really poor. And of course, in the era of the small molecule, there is also a window of opportunity for the JAK inhibitor. This is the first communication regarding the use of JAK inhibitors in childhood chronic uveitis, even though these were adults who started as a GI disease. And of course, you may be aware about these randomized clinical trial that we cannot speak for obviously reason, but the result will be really quite soon available. Lastly, and this is, let's say, the jump for my good friend Ram, going more deeply and go more into detail regarding the pathophysiology of chronic uveitis, you encounter the possibility to use IL-17 as possible mechanism to block into determining the disease. So Ram will teach us about this other randomized clinical trial that is ongoing. Thanks for your attention. Thank you very much.
Thank you very much, Dr. Simonini, for this great overview of treatment and the current guidelines and evidence from current meta-analysis. I remind you that can send us your questions through the website, and we will have time after the two presentations for questions. The next speaker is Athimalaipet Ramanan. He's a consultant pediatric rheumatologist at the Bristol Royal Hospital for Children. He's the joint lead for research at Division of Women and Children at the Bristol Royal Hospital for Children and professor of pediatric rheumatology at the University of Bristol. Professor Ramanan major research interests include genetic aspects of juvenile idiopathic arthritis, juvenile dermatomyositis, and biologics for uveitis in children with EAA. Ram, welcome, and the floor is yours. You have your mic and camera. You must turn on. Okay, great.
Thank you very much, Jordi. And firstly, apologies that I've joined a bit late, clashes with the clinic, but thank you very much, everyone. I'm sure you've had an incredible talk from my colleague Gabriele, so I'm probably not going to say much more than what he's already nicely elucidated. These are my disclosures, and I'll come to that. So you've already seen this slide as I joined. Now we know, like in all immune diseases, uveitis is an immune-mediated inflammatory disease. So not dissimilar to what you see when it happens in the joint, we call it arthritis. When it happens in the skin, we call it psoriasis. When it happens in the gut, we call it inflammatory bowel disease. So we need to reframe our understanding of these diseases and more likely call them IMIDs, immune-mediated inflammatory diseases, which then enables us to consider using the therapies across the spectrum. Of course, there will be some differences. And we think there's a two-hit hypothesis. There is probably an environmental trigger, which we haven't identified yet, and there is a genetic risk factor. There are very good mouse models of experimental anterior uveitis and also experimental pan-uveitis, but the better mouse models are those of experimental autoimmune anterior uveitis. And from these mouse models, we understand really the complex plethora of cytokines which are involved. And we know certainly TNF is a key cytokine, and you will hear and you've heard about data from that. But that's not the only cytokine that's involved. We now have a host of molecules which affect IL-6. We have the IL-12/23 molecules such as ustekinumab. We have IL-23 blockers such as guselkumab and risankizumab. We have IL-17 blockers such as secukinumab, ixekizumab, and bimekizumab. So we need to consider all of these agents because increasingly we are finding a proportion of patients who are either primary or secondary refractory to our current and only approved biologic, which is anti-TNF, and I'll come back to that. And really, to go into a bit more of the immunopathology, there is a complex interplay, and there is a complex interplay when there is breakdown of the blood-retina barrier, which leads to macular edema, and there's a complex interplay before that. And for eons, the eye was always considered as an immune-privileged site. And it is an immune-privileged site, which is why corneal transplants work so well. But this immune privilege is lost when you have an inflammatory milieu. And therefore, local therapies are not the answer. And that's always something people think of. And you need systemic immunomodulation really to manage these conditions. And this is again demonstrating the complex interplay and the host of inflammatory mediators when you have an inflammatory state, such as an endothelial inflammation. You can see virtually every cell type which we think of as being involved in peripheral arthritis or an inflammatory bowel disease or in skin disease has got a role to play in inflammatory eye disease, particularly both in anterior uveitis as well as in pan uveitis. And this is showing why we think we need to consider immune-mediated inflammatory diseases as a continuum. So I'm demonstrating here what happens in arthritis, what happens in a psoriatic lesion, what happens in enthesitis, and we know that the B27 positive adult spondyloarthropathy patients get acute anterior uveitis, and they may be from the IL-17 producing gamma delta T cells. And likewise, we think dysbiosis plays a pivotal role even in conditions such as uveitis. And most of our patients want to know, why did I get uveitis? And maybe some of this will be in the gut microbiome. And of course, there are unknown antigens and inflammatory triggers such as infections. And we see this in certain conditions such as BLAU and inflammatory uveitis in sarcoid in a much better framework. But coming back to, most of us are clinicians, why should we take uveitis seriously? And this slide is pivotal in demonstrating that at diagnosis, 1 in 3 patients at diagnosis have a uveitic comorbidity, and this is most commonly a cataract or a band keratopathy or a posterior synechiae. And by the time you get to 1 year, 3 out of 4 children will have a uveitis complication. So really, we need to do much better both in picking them up early and also in treating them much better. And what are the risk factors for visual impairment? We've got better over the last 2-3 decades, but we have a long way to go. And the risk factors are having a positive ANA, which is more for getting uveitis, but really having a persistent flare, having a raised intraocular pressure or a very low intraocular pressure, which can be quite dangerous, posterior synechiae. So essentially, active uveitis is a risk factor for long-term visual morbidity and loss of vision. So most of my model comes from, we've been running a unified monthly clinic with my ophthalmology colleagues, Andrew Dick and Catherine Gooley, now for 20 years really, and I need to change this slide. We have dedicated pediatric ophthalmology and pediatric rheumatology nurse specialists. We both are in the same room. We have a slit lamp and a couch, and therefore it enables better communication and better treatment really. So where is the current standard of care? We have topical steroids, which we think has limited posterior segment penetration, and the steroids themselves are associated with the risk of cataracts and glaucoma, and I'll come back to that. We have a host of anti-metabolites for which we do not have randomized controlled trial evidence. We can give steroids in the eye. We can inject them either as a subtenon or as intravitreal, but both of those are associated with raised intraocular pressure and cataracts. And then the therapies we want to see more of, for which we need to create the evidence base, and I'll come to, that's the biologics and the small molecules really. But whenever you deal with ophthalmology colleagues of yours, you have to persuade them not to use regular drops. So they usually start at 6 drops a day, 4 drops a day, 3 drops, get down to 1 drop, the eye flares, and they go back to 6 drops, 3 drops. And when you suggest to them that the drops themselves are causing the cataract, they will put it to you, how do you know it's not the uveitis? So Jennifer Thorne did this nice study where she took patients with inactive uveitis who are on more than 3 drops and demonstrated clearly that having more than 3 drops for 3 months is a major risk factor in a quiet eye for the development of cataract. So for all our regional general ophthalmologists, we say if you have a child who's needing more than 2 drops for more than 2 or 3 months, send them to us for consideration of methotrexate. And that's a simple rule of thumb that the surgical ophthalmologist can easily adopt and practice. And oral steroids really might be useful in adults, but it's something which most of us as pediatricians and pediatric rheumatologists realize have a very limited place. So we went on to do the first study, which was my first randomized controlled trial in uveitis. And what we did at that time was take children between 2 to 18. We said they must have active JIA-associated uveitis. Subsequently, I was involved in a European Medicines Agency consultation document where we have now clearly included that children with ANA-positive chronic anterior uveitis is the same disease as JIA-associated uveitis. There is a cohort of children who just have uveitis without getting arthritis. And increasingly, we are seeing the incidence of uveitis and arthritis come down, but not the morbidity. And that's probably because of early use of methotrexate that some of the patients who are destined to get mild uveitis don't get. Early use of methotrexate in idiopathic uveitis means some of these children who are destined to get mild arthritis don't get it. So we, at that time, we didn't have the EMA statement, so we only took JIA-associated uveitis. In my subsequent trials, I take all uveitis. They must have had methotrexate for at least 3 months, and they must be on a stable dose for the last 4 weeks. And we did a 2:1 randomization to make it more palatable for our patients and parents. So you had a 70% chance of getting drug, 30% chance of getting placebo. All of them were maintained on methotrexate with a clear exit clause should they have a flare. The study was stopped after 90 patients by the independent data safety group because there were only 16 treatment failures in the 60 patients who got adalimumab compared to 18 treatment failures in the 30 patients who got placebo. And you don't need to be a statistician to work out that that's highly statistically significant. Of course, what do we want to achieve in clinic? We want to get our patients to have zero or minimal cells on zero or minimal drops. So it's important to look at the drops. And you can see that the ability to achieve zero drops was greater in patients who had adalimumab. And of course, zero drops is not possible, but 2 drops was also greater in patients who had adalimumab. Then comes the next question. Okay, adalimumab works. How long do I give it for? 18 months, 3 years, 4 years? So in a subset of patients from this trial, about 28 of the 90 who were recruited in our center in Bristol, which caters to a population of about 6 million, we followed them up. And what we showed is in all bar one of the 28 patients, that is in 27 of the 28 patients, stopping adalimumab led to a flare of the disease, usually flares somewhere between 6 weeks to 3 months. And if they go past 3 months, they are less likely to flare. So we still, and this could be for 2 reasons. One, we probably miss the immunological window of opportunity where we can switch the disease off, or uveitis needs long-term treatment with adalimumab, much longer than we are used to as pediatric rheumatologists for our arthritis patients. And of course, globally, we're all switching to biosimilars, which makes it much more affordable for our governments. So we looked at the switch, which we did in 2019. It was mandatory in UK. So we looked, because uveitis offers the unique opportunity of having an objective marker at every visit in the form of slit lamp examination. So we looked at the efficacy of biosimilar switch from 2019 to 2022, mainly in Bristol, and added a smaller site of Sheffield, and included a small cohort of adults, but 2/3 children. So the overall cohort was 60 patients, 40 of whom were pediatric patients, and just under 20 were adult patients. And the pediatric patients were predominantly anterior uveitis, and the adult patients were a smattering of pan, posterior, and intermediate, only a small number of anterior uveitis. And what I'm demonstrating in the take-home message is the number of flares prior to switching from adalimumab to biosimilar and the number of flares after switching to a biosimilar are no different. So in essence, suggesting that the biosimilar might be cheaper, but it's as effective as the originator molecule, which is incredibly reassuring for both our patients, parents, and to us as clinicians, really. As Gabriele alluded to, we felt it had taken such a lot of effort in organizing a uveitis trial that we didn't want to lose the momentum. Now, what was clear from the Sycamore trial was while adalimumab was incredibly effective, there was still 30% of the patients who were not responding to adalimumab. And we all know that if you follow them up long enough, a proportion of the patients who are responders become non-responders. Most of these are due to the production of anti-drug antibodies. And if you measure drug levels and anti-drug antibodies, you will see that some of them will have low levels and high anti-drug antibodies. So there is a need for alternative agents, both for primary non-responders to adalimumab and secondary non-responders to adalimumab. So we went on to do a phase 2 trial of tocilizumab in anti-TNF refractory patients. Why tocilizumab? So there's a clear correlation between the aqueous humor levels of IL-6 and the central macular thickness. And we know that the more macular thickness or macular edema you have higher levels of IL-6. Now, IL-6 is a pluripotent cytokine. It's key for Th17 differentiation. And when you have breakdown of the blood-retina barrier, you will have the pro-inflammatory effects of IL-6 mediated, which is best seen in the case of macular edema, but it can mediate a whole host of actions, as I've demonstrated in this slide, really. So Marina Mesqueda, when she spent time with us and then when she was working with Alfredo Adan, clearly showed some beautiful pictures that you can see here of dramatic resolution of recalcitrant macular edema with IV tocilizumab. And so there is enough mechanistic evidence, there is anecdotal evidence for us to go on to do this study, which I think was not well known because it was published in the throes of the pandemic, really. So people may not have really missed the fact that it's even come out. So who did we target? We took children between 2 to 18, JIA-associated uveitis. They must have failed both methotrexate and an anti-TNF agent. They were all given subcutaneous tocilizumab because that was the standard of care, and that's what our government wanted us to do because it avoided infusion costs. And we tried to look at the standardized uveitis nomenclature of the SUN criteria, a two-step decrease from the start of treatment and to the primary endpoint, which was at 12 weeks as primary response. Because these are moderate to severe patients, we adopted a novel study design, which has been used in pediatric oncology. Whenever you get cancers and a new drug comes, everybody wants to use the drug. So you want to try and give equitable access to all the patients, but without subjecting all of them to the harms. So our two-stage design was after we treated the first 10 patients, we said if we didn't have at least 2 of them respond, we wouldn't go to the full 22 patients. And we defined response as having a 2-step improvement, partial response as having a 1-step improvement, and non-response was those who didn't get a 1 or a 2-step improvement and worsened really. We recruited 21 patients in all, and 7 of the 21, and remember these are patients who have failed both methotrexate and an anti-TNF. 7 of the 21 patients had a very good response really, and you can see some of them going from 3+ to 0, 4+ to 1+. But there were another 10 patients in whom there was no response, and some of them the disease got worsened, and a further 3 patients in whom was partial response. The partial response is particularly important because 1+ patients, it's very hard to get them to go to 0. Any of us, if we have our eyes looked at in a slit lamp today, may have 1 or 2 cells. That makes us 0.5. So achieving 0 cells is sometimes very hard in a trial if you've got a very objectively minded ophthalmologist looking at the slit lamp really. So the key message is a third of the patients had a 2-step improvement, and these are patients who have failed an anti-TNF and failed methotrexate. And a further 14% of the patients had a 1-step improvement. So almost half of the patients had some improvement, but the other half didn't. And those with cystoid macular edema dramatically improved, as we know from before. And the safety, we're all very comfortable with the use of tocilizumab in systemic JIA and polyarticular JIA. I showed this picture just to provide a bit of interest again. These are a series of Blau patients in which we have an interest. And I show this because in those resource-limited settings where you are not easy to get exome sequencing, the Blau patients really have a characteristic ocular phenotype, which is they have this peripapillary choroidal inflammation, which can mimic TB, but it's got its own image really. And of course, the Blau is a completely different autoinflammatory condition with pan-uveitis and sight-threatening ocular disease really. And this is that peripapillary multifocal choroidal appearance that I wanted to emphasize for those who are ophthalmologists in the audience really. Of course, the world of pediatric rheumatology is pretty excited about the small molecules for 2 reasons really. One, that they are oral, and 2, in resource-limited settings, the small molecules will be incredibly effective because they're very cheap once the patent expires. Even though they may be once a day tablets, we have to remember these are again quite powerful. They have very many mechanisms of action. They work on hematopoiesis, they work on growth, they block IL-6, they work on Th17 differentiation and IL-12/23 pathway. You can understand why that they are approved for inflammatory bowel disease through their 12/23 pathway, IL-6 and rheumatoid arthritis, the interferon pathways through which they work in COVID, for which I did a couple of randomized trials in adults. And of course, you've got a whole host of selective and non-selective JAK kinase inhibitors, the non-selective ones like tofacitinib, and the JAK1/2 blockers such as ruxolitinib and baricitinib, and more JAK1 specific selective ones such as filgotinib and upadacitinib. And so how do they work really? The JAK-STAT pathway results in the phosphorylation and the autophosphorylation of the JAKs, which then phosphorylate the STATs, which then mediates the transcription of the pro-inflammatory cytokines. And these pro-inflammatory cytokines will mediate the damage, be they in the joint, the gut, the skin, or in the eyes. And in the joints, you can clearly understand what they do, that they will cause the erosions that we see in adults with rheumatoid arthritis. And what our small molecules are doing is blocking this autophosphorylation and therefore blocking the JAK-STAT phosphorylation. And of course, you have variable efficacy, but you can see the JAK inhibitors are particularly effective across a range of indications compared to several of the other molecules except TNF. So I am and was cautiously optimistic that the JAKs might prove to be similar to TNFs. And of course, I also want to put a plug in that really pediatric rheumatic diseases no longer should have placebo-controlled or withdrawal designs. It's really unfair to give the drug to a patient population, take the drug and show that they're getting worse. So we designed the first, what I would like to say, an adaptive design Bayesian model head-to-head, where we had patients randomized in two arms, really. The adalimumab refractory patients who all got open-label baricitinib, and then the adalimumab naive patients who got a 1:1 randomization to adalimumab or baricitinib. I'm not showing you the data here because it will be presented at press, and I just presented it at EULAR. I could have shown it, but I wasn't sure if I got the appropriate permissions. So come to press. It's a plug for you coming to press to see the data, really. But we just published this case series showing tofacitinib is very effective in refractory uveitis in a series of children with who had failed multiple biologics in a big ophthalmology hospital in Chennai, which is my hometown originally. Of course, we want to look at multiple molecules, and I said to you already, there's a raft of IL-17 blockers and IL-12/23 blockers. I already mentioned about the 23 blockers, such as guselkumab and risankizumab, which is really revolutionizing the world of psoriasis and psoriatic arthritis. The ustekinumab, which is a big role in inflammatory bowel disease, and of course, IL-17A blockers, such as secukinumab and ixekizumab, and the IL-17A and F blockers, such as bimekizumab. So we're running currently about halfway through this study. We're trying to look at the role of secukinumab in JIA and idiopathic chronic anterior uveitis. Again, it's a two-stage design. So the first 10 patients are those who are adalimumab refractory. And in our stop-go model, we must have at least 3 responders out of these 10 for us to then go to our second phase of the study, where they'll have a 1:1 randomization to either secukinumab or adalimumab. And one of the things we're doing novel in this study is the dose of secukinumab, for those who are unaware, is 150 and 300 in juvenile psoriasis if you're over 50 kilos, under 50 kilos, whereas for juvenile psoriatic arthritis, it's 75 milligrams and 150 milligrams. Now, there is a lot of mechanistic data and anecdotal data, clinical data, suggesting that the uveitis patients seem to need higher doses. So in this secukinumab trial, we're using the juvenile psoriasis dose of 150 milligram and 300 milligram, rather than the juvenile psoriatic arthritis dose, which is 75 and 150 milligram. Time will tell. And again, sometime later, in a year or 2 years' time, if I'm invited again to an ERN-RITA meeting, I'll come and show you the data of this study. We all have experience of dealing with a proportion of patients who are really refractory. They have failed infliximab, they failed adalimumab, they may have failed tocilizumab. So we are running this trial of an implant. Now, these are for the very severe pan-posterior uveitis patients who have failed multiple small molecules and biologics. And of course, one of the major problems with an intravitreal implant is you will get cataract and raised intraocular pressure. So most of the patients who are suitable for these therapies would have probably already had cataract surgery and may have had a trabeculectomy and may therefore will not be at risk of either cataracts or raised intraocular pressure. Of course, what does the future look like? There may be novel therapies we can target, such as IL-35, looking at the Treg pathways, and of course, trying to understand more about the pathophysiology. But let me come back to where I started. In spite of us having an explosion of therapies in our own center, when we looked at our outcomes about 6-7 years ago in the biologic era, we found that 3 out of 4 children will need methotrexate, those who come to our inflammatory eye disease clinic. And about 1 in 10 will need 2 biologics. So 3 out of 4 needing methotrexate, 1 in 3 needing a biologic, and about 1 in 10 needing 2 biologics, really. And our outcomes are still, we have a long way to go. Children with JIA-associated uveitis are highly likely to develop raised intraocular pressure and glaucoma, and idiopathic uveitis can get sight-threatening macular edema. And unfortunately, cataract is still a frequent complication, and a third of the patients at presentation had an ocular comorbidity, with posterior synechia being the most common. So we have a long way to go. And of course, what we need to do is go towards precision medicine. We need to go for the right drug for the right patient at the right time. And we are trying to do this through the cluster consortium within UK, which includes JIA uveitis as one of the work streams. I'll stop there and leave enough time for questions and acknowledge all of those who funded me and all my colleagues. Thank you very much.
Thank you very much, Ram, for this great talk, and also to Gabriele. The floor is open now for questions. We have some that are arriving through the website. And first of all, according with your presentation, Gabriele, and also Ram, do you think that nowadays we have current evidence to select a group of patients to a more appropriate therapy instead of just proceeding with an algorithm about methotrexate, adalimumab, or whatever? Is there enough clinical data or biomarkers that could help us to select the better patient for the best treatment?
In my opinion, not yet, Jordi. Sorry, Gabriele, you can add. In my opinion, not yet. Probably the only clinical marker at best which will enable us to choose between the biologics is for macular edema IL-6 blockade. But that's the next step. We need to find those biomarkers. We need to be able to personalize the medicine to our patient population and not do the cycling as you suggested.
I'd say that I agree with Ram regarding biomarker. There are no specific yet. There are no specific biomarker that can narrow you your right time, your right decision, your right solution for treatment. But I can say now that there is now enough evidence for narrowing the clinical feature of different uveitis. I mean, an anterior uveitis is a land. A posterior uveitis is a different question. So when there is sign of vasculitis, this is my opinion, of course, even though there are evidence. If there is vasculitis, as Ram suggested, if there is macular edema, if it is a panuveitis, probably there is no need to have a by time escalation, methotrexate, wait, then see anti-TNF-alpha. For a macular edema is a big complication, even for just time. So to me, it's enough to jump to a biological treatment. For a vasculitis, uveitis, probably methotrexate a little bit wasting time. It can be an helper, but it cannot be the first choice or the first treatment.
I also would like to know, I mean, Ram, the study of attitude was very interesting, but as you know, in some other trials, we have seen that the response to a biologic, which is the third option, is not the same as it's considered the first option, for example, with abatacept, no, in GAA. So which would be your impression if you could have been able to use, I mean, tocilizumab, a first option of a first biological in these patients?
That's a great question, Jordi, and you're absolutely right. Trying a drug in a refractory population is setting it up to fail. The problem is, when I show the data in press, you will see, I could not recruit for the baricitinib study for the adalimumab naive arm. The problem is all our patients, when you offer them a clinical trial of adalimumab versus something else, they want the proven drug. Particularly with eyes, you can understand the families are very anxious. So that is a problem. And I think I'm making the same, you call mistake, again in the secukinumab study, because I'm setting it up to fail. I'm choosing the adalimumab refractory patients. I don't know how to solve this problem because the response to adalimumab, the universal approval of adalimumab, the access to adalimumab has made it very hard to do clinical trials in uveitis in the adalimumab naive patients. There's another mistake I also think I made in adalimumab in my tocilizumab study. I didn't use a higher dose. I should have used a higher dose. I don't think I would have used IV because that carried more logistical problems for me, but I could have used a higher dose, which I didn't. So I'm trying to remedy that mistake in my secukinumab study.
Nice. We have a question from one of the attendees. Thank you for your presentation. Which therapy would you propose in case of possible side effects of adalimumab, such as interstitial pneumopathy in a patient with GIA and uveitis, well controlled by adalimumab? So I believe that it's a patient with adalimumab who is developing interstitial disease, which will be your option.
Interstitial lung disease?
Yes, that's what he said.
Yeah, it's a challenge. Firstly, I'd want to know what is the disease process which is causing interstitial lung disease, and probably try and see, because we have better access where that person is to exome sequencing and so on. Mm-hmm. But what I didn't show in the interest of time, and I think Gabriele alluded to, is we have a cohort of children which we have now published who, if they don't respond to adalimumab, of course, that isn't the question that's being asked, do respond to infliximab, which is a bit of a paradox. And I don't use the high doses of infliximab that some of my North American colleagues use. We published a series of 22 patients who have had resolution of their uveitis with just 6 milligram per kilogram maximum every 4 weeks of infliximab. I do not use more than 6. So if I would first want to ascertain what disease this patient has before I change the biologic.
Which is your experience, Gabriele?
Well, I would say pretty the same. I mean, overall, I'm not able to properly answer regarding the pneumopathy interstitial strongly related to adalimumab. It's hard to say to me. Anyway, if you are, in my opinion, if you are really persuaded that a potential side effect is strongly related to adalimumab, my reaction is try to swap rather than to switch. If you are strongly persuaded that adalimumab causes this side effect, it could be safer to change the class and using a drug as a tocilizumab. Moving from side effects related to adalimumab, I'm totally agree with Ram, even though I'm using a higher dose than infliximab, not as our North American colleague, but 10 milligram per kilogram is the dose that I use. Usually I do not go over 15 or 12.5, but most of the time when I decide that it's the time for infliximab, 10 milligram is my preferred dose.
Thank you, Iman. It's a fantastic, we have a last 2 questions, and to take advantage of having 2 great experts here. One of is, do you consider there is a window where you could use anti-TNF at the diagnose of a uveitis patient? I mean, or you will start always with methotrexate? I understand that what it means is there a group of patients with severe uveitis would you will consider anti-TNF right from the beginning, plus or minus methotrexate, or you always go first methotrexate plus anti-TNF later?
No, absolutely. I always, for those with severe uveitis with ocular comorbidity, we go straight for anti-TNF plus methotrexate. But the more interesting question that you highlight is there an immunological window of opportunity, a bit like what the Dutch colleagues are doing with systemic JIA, whether even for the mild to moderate, if you go straight with the biologic, you may be able to switch the disease off. That might be a more feasible trial to do. But for the severe patients, currently, we go straight with biologic and methotrexate.
Which is your experience, Gabriele?
Probably because he's a friend of mine, but I totally agree. So using methotrexate for a new onset uveitis with from the beginning severe complication that affect the visual acuity. Using methotrexate alone, to me, is just wasting time. Different if you use plus adalimumab. So adalimumab plus methotrexate is another question. So for select, at least by now, if the regulatory rule does not allow too much, but however, if there are already some complications that are really affect the long-term outcome of the visual acuity, adalimumab from the beginning plus methotrexate is this the right choice for me, as Ram told. And
that's
again,
very challenging, and for sure we need to know what the health regulatory will permit us, no, or if we have enough data to strengthen this message. And the last question, we have been talking about how to start new treatments, how to increase them, how to escalate them, which are the best options. What about the weaning? I mean, that there are not so many trials on that, and it's also very important. Which is your practice, your recommendations?
So there is a trial, Jordi. The paper is going to be submitted anytime today or tomorrow to a top journal. So it's called the ADJUST study. We set out to do a 118 patient randomized trial, placebo-controlled switching or stopping study across US and UK. We stopped the study after 86 patients based on independent data safety monitoring, so you can guess what the result would be. But what we did was we took patients with minimum 1 year well-controlled uveitis, and half of them were switched to placebo and the other half continued originator adalimumab. So that study will show two things. It will show how long we need to wait before we stop, whether there are biomarkers which will help us predict patient, which will take a bit longer. I would watch this space, and if there's another ERN-RITA meeting, I will showcase those results.
Okay, that's very promising. And in the meantime, Gabriele, which are your recommendations?
Well, waiting for a selected biomarker that open the bracket. I think that we are not so far for having a biomarker, and I'm not speaking about a high biomarker. Closing bracket. In the meantime, it's according to the clinical activity and the time from the beginning, the inactivity of the disease. So overall, even though each one of the decision has to be customized for each children and for each eye, I would say, well, do not stop the treatment before 2 years of persistent inactivity. Try to wean the dose rather than the injection, and then weaning the injection according to the different treatment that you are going to use. And most important, because waiting for this miracle biomarker increase the number of the eye consultation when you are weaning the treatment, because you know better than me, most of the time these are asymptomatic disease. So well, we are confident that if a treatment doing the job on the treatment, you can also increase the time between the eye check. But when you are going to weaning, pay more attention and put some money in increasing the frequency of the eye check.
Thank you to both of you for your talks and your great experience to share them with us. I mean, I believe it has been a really brilliant webinar. I hope to reproduce it in the future with new literature, with new reviews. And for sure, there are a lot of things in the table, biomarkers, weaning, how we must monitor well with these patients, multidisciplinary teams, with your experience. In the meantime, thank you to all of you. Hope to see you soon. Have a nice summer.
Thank you.
Bye.
Bye.
Bye.